really on the conversations and the takeaways from our various work group. We have about 5 minutes for each. And so I will start off with, let's do our vaccinations COVID-19 work group.
Sure, I can speak to what we have on our Jamboard. So the participants were myself, Sophia with Race 6 and 7, and then we had Kaylin with Region 4, and then Jason with Denver Health. And so I think we had a lot of themes that all of the Rays have been really working on to increase capacity around not just COVID vaccinations, but obviously overall routine vaccinations. So really just providing continued support to our primary care networks, education, training, and DEI workshops, improving data collection and analysis, getting a little bit more creative around incentivizing vaccinations, so immunization contests and incentives, working with our local health equity leaders, promotoras, community health workers to find and promote messages within their communities. Denver Health's clinics are currently focusing on patients' vax via office visits, combined with walk-in capabilities. We also had Marius from HICPUF join, and some of HICPUF's efforts that were outlined are collaborative work with CDPHE to approve the VFC program in pharmacies. So with the public health emergency going away and pharmacies no longer able to offer vaccinations if they are not VFC certified is a huge barrier, because a lot of the data is showing that members are getting vaccinated within pharmacies. So just kind of increasing that capacity there. Also just improving intake assessments to standardize data collection. So yeah, I think data was a huge one, of just making sure that we are continuing to collect data. And especially as, we are waiting for the FDA to put out the final schedule, aligning those efforts with potentially flu and other routine vaccines. And then making sure that we were able to actually collect data on what that updated booster is. So yeah, I think those were the main themes, but I don't know if anyone else from my group wants to add, please feel free.
That's a nice sharing. Thank you so much, Sophia, and the group for all of your great ideas. So I'll call on the maternity group next.
Hi, this is Issei. I can go for our team since I was the note taker, and excuse the background noise. My son is at home with me today. So I think we talked a lot about data as well, and just making sure that there is data available on things like severe maternal morbidity, and that data can be disaggregated by race. We also talked about providing culturally competent care, making sure that that's available in all aspects of healthcare. Early access to data for pregnant women, so meaning like if someone is testing positive for pregnancy, that the Rays are notified as early as possible so that they can have the opportunity to provide resources, and prenatal care can be provided. Another great idea was doing that screening for social needs and SDOH factors at the time of application for members for Medicaid, so that if there are any social needs that are available, that can be identified as early as possible, so that the problem doesn't persist, especially if there's solutions. Training for providers to empower patients to make choices on how their care will go, instead of sort of just doing a plug and play, and having meaningful discussions about what birthing persons want and how they want their maternity care to go, whether they want to be at a birthing center, if they would like doulas present at their care, those kind of things, and not just making assumptions. Better support for community organizations that provide non-traditional maternal or cultural support. We talked about making sure there could be credentialing and reimbursement pathways that the state could get clarification and support that work that's being done. Creating culturally responsive birthing centers across Colorado is important, as well as diversifying the workforce. I think I said that. We talked about specialty care and how that can be challenging for members who are receiving Medicaid as insurance to get specialty care, especially on time, and that's especially compounded if a member is living in a rural setting, and so just making sure to see if there's opportunities for changing reimbursement or providing incentives to improve access to specialty care. And I think those are the big ones. Oh, better screening and resources for perinatal and postpartum mood and anxiety disorders. And it was also called out that we have to make sure that we are doing the screening for, and in that 12 months post the birthing event to make sure that we don't miss any opportunities to provide care as well. I think those are the ideas that we came up with, but I'm encouraging my team to add anything that I missed because I'm trying to read across the notes pretty quickly.
Right. Well, that's a fantastic list so far. Thank you, Essie. I'll call the behavioral health group next to do your report out.
I can jump in. All right, so the Behavioral Health Task Force work group. With relation to upstream, we had a lot of discussion about addressing some of the systemic bias that occurs in the education system that providers go through. We originally were talking a lot about just how to better educate our providers, and that led to the discussion, well, if they're better educated to begin with, then we would not have to go back and add in a lot more education for our providers, which is a much larger issue. But it kind of sparked quite a bit of discussion. One of the other topics we talked about was helping providers be more of health partners in care, rather than the experts who hold all of the knowledge and are giving that to the patient rather than working with the members. We also talked about increasing peer involvement in care, so improving the credentialing process, as well as promoting the credentialing process for peers with shared and lived experience to help sort of bridge between providers and the patients that they're serving. We talked a lot about having a way that providers could demonstrate that they are knowledgeable in the area of health equity, so that they can communicate that to patients to build trust with patients in various communities, that this is a provider who does understand some of the health equity and disparities that occur, and that is a provider they could trust and see. We talked about providers getting more integrated into the communities. So going into the various spaces in their community where there isn't a lot of provider representation and building that trust on a real kind of grassroots community-based level. Because a lot of folks, when you're asking for a type of provider to see, a lot of times you're asking your friends and your family and your, maybe coworkers to say, hey, do you have a provider that you would recommend? So helping them become more active and engaged in different community would help build some of those more natural referrals. Another really great suggestion was to increase that provider's sort of visibility and building that trust is to have them have videos, like introductory videos on their website, to sort of allow members to see who they are, to hear who they are, to hear in their own words what type of provider they are before they even walk in the door. We talked a lot about cultural, that building that kind of cultural health equity in the whole organization, that a lot of times you've had contact with your receptionist, the person who does your scheduling, the nurse who does the screening, well before you ever even get to the actual provider. And so ensuring that that education is not just directed at the providers, but directed at the entire organization, because the tone is set when you first walked in the door, and the way that maybe front desk person greets you, or how they talk to you on the phone, or what accessibility they have available when you try to make your appointment. So kind of trying to make that more pervasive through a whole organization. We also talked about broadening telehealth options to increase capacity and access. That there is definitely a capacity and access issue in behavioral health in general. And sometimes those capacity and access issues really prevent providers from actually fully engaging in some of the health disparity work that I think a lot of them do want to engage in, but because they are so significantly overloaded in this area, don't feel like they have capacity to engage in this work. So just increasing that telehealth would also increase access for some of our more underserved areas in our state that don't have a lot of availability or options. Let's see, what else? I think the other thing too was supporting members and getting more engaged in their healthcare. So helping educate members on the benefits of behavioral health, how to get engaged in behavioral health, why you would want to seek behavioral health, but to have that education come from, again, members with lived experience. It's a little bit more valuable, and I think probably carries a little bit more weight when you're hearing it from a peer. Versus a provider who's providing the service saying, yes, come and use my service. That's nice, but it also, again, to the point we made earlier too, about having references from people that or people who are like you or look like you or sound like you or from your community, carries a lot more value than maybe necessarily just a provider saying it. So anything that I missed from our behavioral health group? Okay, I'll turn it back over.
Thank you. Well, that was fantastic and very comprehensive. Thank you so much. So next up, I'll call on the prevention work group to do a report out.
I'd love it if Aaron helps us because he took really good notes.
I think Aaron had to jump off for another meeting. So I don't think he's on with us.
We filled up those 3 slides, I'm pretty sure, with all kind of good stuff. And I gave kudos for one of the departments getting almost 5 stars on their Google review. I love that.
Yeah, I think a lot of the stuff was already said. We're kind of in alignment around building awareness around services, what value they have, leveraging in, community engagement and kind of hosting more conversations between different sectors of industry to kind of build that trust, understand benefit and value of prevention, how employers can be involved and how education can be involved, but also probably, reallocating some of the resources that exist in other departments into areas of the healthcare industry so that capacity can be built in certain areas so that health equity and these other, these campaigns can actually be prioritized because there's a foundation that's already existing on how to communicate out to your community, how to, build awareness around your services, and also develop relationships with other types of organizations. But I think there's a lot of things that we already kind of acknowledge that there's just a lot of education and communication and advocacy that needs to happen just around the value of accessing care early and maybe ahead of time. to build that relationship with your provider and feel comfortable and confident to go to them and know what your access points can be. I would just preface that I jumped in for the first time this time, so yeah, again, I'm just trying to at least share.
Wonderful. Thank you, Sarah. Our last group is access to care. Who would like to report out from our group?
I vote for Erica. Just kidding, I could. So we spoke about the lack of understanding that currently exists among providers about how to deal with people with different disabilities and abilities, especially including invisible disabilities. How can we address those type of issues so that people who have those type of disabilities are not afraid anytime that they have to visit a new provider that they don't know and does not know them, and we talk about how important it is for those providers to listen, to hear those stories, those experiences from people like us, people who have lived those situations and often get misinterpreted or mistreated, not necessarily abused, but in some cases, yes, or underserved because of our disability, and or sometimes because of our different cultural understanding of interactions, etc., etc. So we spoke a lot about the importance of including BIPOC populations in the education to those providers, and also including those type of trainings from the get-go, so that they know that part of the Medicaid or insurance, etc., requirements are that they work with this type of people. Also, we spoke about, correct me if I'm forgetting something, Juan or Erica or anyone, but we also spoke about, let me refer back to John Ball. I remember that we have that. But we talk about a lot of things: education, culture, sports training, utilizing people who are retired, web support so that people know what kind of provider, whether they are already have been trained as DEI providers, etc. Also, a lot of our training, we talk about the right cultural training, cultural competence, creating directories of specific providers that are open to serving different types of populations like LGBTQ+, people with disabilities, or with certain types of disabilities, who have certain types of accessibility, who have specialties, for example, mental health, etc., so that we are not running into those obstacles from the get-go. We know whether it's from HICPOP or from other websites in the state, what those providers are that we can access. Am I missing something, Juan?
Oh, fantastic. Thank you, Jose. Our work group talked for the entire time and we didn't realize that the clock was running and the work group session ended. So we were still talking of that.
Yeah,
Yeah.
We were still talking when they pulled back.
Yep. So, the report outs are very impressive. Thank you for your existing work and innovative ideas to help us advance in our different focus areas. And we value all the contributions. And so know that what you shared verbally, as well as what you shared through the sticky notes on the Jamboard, will be taken and more analyzed and aggregated, so we get some few key steps moving forward. So we only have wow, time flies by pretty quickly. It's been almost the end of 2 hours. So we want to just spend this last few minutes to hear from you. And we don't need to share out the screen anymore, Dana. Thank you so much.
I just had one thing I wanted to share.
Okay.
And so I
Yeah.
had the slide up. That's why I put the slide up. just
Oh,
'cause I have
okay.
a slide.
Yeah, so this is our sharing period. So let's share.
Yep, and I will do this real quick and then I will turn it over to you all to share. But I just wanted to share that the Office of Management and Budget, the OMB, collected public comments on their proposed updates to race and ethnicity statistical standards earlier this year. And there's going to be a listening session that is scheduled, a public listening session for August 24th. So 11 a.m. Mountain Time. It's going to be only 30 minutes, and we've listed the link on the slide. And again, well, I'll share an email with all this information again, but just wanted you all to be aware that this is taking place if you want to jump on and listen. So they're kind of extending their public comment period to hear from some community organizations and such, but I will get more information out on this to everyone, but I just wanted to share this real quick now, and I'll stop talking and I'll let others share.
Oh, this is a very important session to attend.
Right.
Yep.
Thank you.
You're welcome. And then again, I'll share out more details and additional information via an email, but we wanted to get this out today since we were meeting, and we had a meeting earlier this morning regarding this. So more to come. So just mark the August 24th date.
Yeah,
for
absolutely.
listen.
I think I saw in the past some guidelines for race and ethnicity collection from the Agency for Healthcare Quality. So it would be great for some collaboration alignment between those two organizations.
Yep. So I will stop the share now and we can share community-wide.
Mhm. This is our period to share anything that you'd like to bring to the work group, to our Health Equity Task Force. Good news or events or just any information like Dana had just shared.
Elisa, are you present?
Yes.
No, Elisa.
Okay.
Elisa.
Elisa,
Oh, Alyssa,
yes,
I thought you said
I
Erica.
am.
I'm so sorry.
I think
Yes, I
it
am.
will be. I think it will be important to share what we have, the conversation we had yesterday with the city, a little bit, even if not in deep detail, just because I think this group needs to be aware of some of the stuff that are happening.
Yeah, well, in summary, Grupo Vida has been helping some families that they are in the shelters. And one of the things that was a kind of issue was as a nonprofit going to the shelter. Therefore, they have a specific protocol that they didn't have before. But one of my concerns is they have a pregnant woman, babies, newborn babies, that the group of staff, they are trying their best to help the families to go to Medicaid, to go to WIC, but it seems that has been a long way. Some moms has an appointment for a month, And currently they are not providing lunch. They indicate us that they are not providing lunch because they were wasting. However, we have a lot of kids, a lot of people with disabilities, a lot of families, and they are they need a lot of support in that area. And Jose, if you can provide more input of the
Yeah,
meeting.
absolutely. Absolutely. So we had an emergency meeting with some representatives of the city, Elisa and I, and they said a few things that I'm a little trouble about, because I do get the responsibility to respect some FDA standards, some quality standards and all that. I also get that when you have a shelter of people of different countries, different races, different languages and cultural backgrounds, of course you will run into problems, but that doesn't mean that you have to start denying services, basic services, while saying in public that you are providing those services. And in my initial thinking of what they said, they are reporting use of funding of the city that is not actually being used for what they're saying that they're used. I'm starting to wonder, and I didn't want to raise hell yesterday, but it makes me wonder if those funds are being rerouted somehow in a wrong way. And I actually am thinking, and Elisa, I didn't share this because this occurred to me last night. I'm going to reach out to Chris Hines because he's a good friend of CCDC, and he's a good friend of ARC, etc. And I'm going to share this with concerns with him, and actually pull him into the fall to see if he can get me meetings with higher up people. Because I do get the responsibility, like I said, I do get the responsibility for cleanliness, for quality control. I get that. And I get that we don't want to waste resources that are already short. But I also get that if you plan ahead, there will be no waste. You are clear in your instructions to people who are in shelters, there will be no waste. They need these resources. They need food. They have nothing in some cases.
Jose and Alicia, thank you so much for sharing, and we can continue the conversation offline so we can understand more and know how to support. And we are kind of wrapping up, and so I wanted to let everyone know, thank you so much for your time and contributions today. And our upcoming task force meeting is July the 19th, where Jose will be facilitating on the topic of CMS Health Equity Priority 5. So thanks again. Have a great day.
Thank you, everyone.